Dear all, Namaste. In this video, I will be describing about peritonsillar abscess or Quinsy. Quinsy or peritonsillar abscess is defined as collection of pus between tonsillar capsule and superior constrictor muscle. This condition is usually found towards the upper pole of the tonsil, where there is more of the loose areolar tissue, and less commonly found towards the lower pole area of the tonsil. The basic pathology behind Quinsy is the infection by aerobic and anaerobic organisms. It may occur de novo, that is on itself, or may be a sequelae of acute tonsillitis, where there shall be blockage of the crypts, especially crypta magna, leading to intratonsillar abscess, and peritonsillitis, inflammation around the peritonsil area, and leading to Quinsy. The significance of crypta magna is that it can reach up to the tonsillar bed. More commonly proposed theory is abscess of Weber's salivary gland in supratonsillar fossa. The abscess leads to Quinsy. As I already told, the upper pole of the tonsil is made up of loose areolar tissue, and the infection can spread or the pus can expand in the upper pole area and can reach up to the intertonsillar pillar and the soft palate, and there will be bulge in the soft palate. What are the clinical features? This condition usually happens in young adult, although it may happen in children or elderly individuals. There will be severe rhinophagia, fever, halitosis, and muffled voice, also called as hot potato voice because the problem basically lies in the oropharyngeal level. The voice will be like a hot potato keeping in the oral cavity or oropharynx. The patient may have a history of recurrent tonsillitis or may not have any history of throat pain in the past. Patient occasionally cannot open the mouth properly. There may be auditory trismus of different grades. While looking on the oropharynx, the peritonsillar area will be swollen and congested. The tonsils get hidden behind the anterior pillars. The tonsils may be pushed medially or may be congested. Occasionally, it will be difficult for us to look on the tonsils because the soft palate area will be very much swollen because of soft tissue. The patient may have enlarged and tender zoogodigastric node, and the patient may have torticollis also. Occasionally, the patient may be in respiratory distress, will have a toxic look as well. Looking on the symptoms and the signs, we should suspect a case of peritonsillar abscess, and we have to go for investigations and treatment. Blood investigations are to be carried out to look for toxicosis and for lymphocytosis. How to diagnose the condition? Looking at the symptoms and signs, we should be able to diagnose this condition. Peritonsillitis and peritonsillar abscess can be differentiated by wide bore needle aspiration. We usually use 18 gauge needle. We insert the needle in certain area which will be described later on, and if that aspiration reveals pus, then it is sure that patient is having peritonsillar abscess. If pus does not come, then maybe peritonsillitis or our needle may not have pierced exact peritonsillar space. How to treat medically? The patient requires urgent admission to the hospital. IV fluids are to be given for adequate rehydration because patient will be dehydrated. Patient cannot swallow the food. Patient cannot even swallow the liquids, and occasionally patient may have absolute dysphagia, that is, difficulty to swallow his or her own saliva. Broad spectrum IV antibiotics covering gram-positive, gram-negative, and anaerobic organisms are to be given like ceftriaxone and ordinazole. IV or IM analgesics are to be given to decrease pain. Antihistamines and decongestant drops are to be used for adequate breathing from the nose because the soft palate will be swollen. Antiseptic mouthwash along with topical anesthetic mouth gargle can be used. A nick is made above and lateral to the junction of two imaginary lines, horizontal along the base of uvula and vertical along the intertonsillar pillar. The incision is widened with sinus forceps and pus is drained. If we use the Thelenius peritonsillar abscess draining forceps, then sinus forceps is not required because peritonsillar abscess drainage forceps functions as both incision and drainage forceps. If we make an incision with the blade, then we have to use the sinus forceps. But we need to be careful that the forceps should not go very deeper, otherwise there may be chance of damaging the internal carotid artery, which is basically a theoretical condition. So don't go more than ½ inch. This picture shows the incision site. There are two imaginary lines. One is along the base of uvula and next is along the intertonsillar pillar. This is the incision site. And this is Thelenius peritonsillar abscess draining forceps. This has pointed edge and there is a mark here. And this works both for incision and drainage. In the past, this forceps was also called as 6 months forceps because if the student could not answer this instrument, he was called upon after 6 months to reappear in the exam. Once the primary treatment is done, patient requires surgery. We prefer interval tonsillectomy, usually after 4 to 6 weeks. After the condition subsides, sometimes hot tonsillectomy or abscess tonsillectomy is also performed. This has to be avoided as it leads to more bleeding due to infection and there may be septicemia also. But second attack of Quinsy in adults is an absolute indication for tonsillectomy. You must have seen the previous videos. I think this video is informative to you. If you like this video, please subscribe my channel, Dr. Krishna Koirala, for further videos like this. Thank you very much.